Hello everyone, and welcome to today's Congressional briefing. The PAIN-DEMIC, fallout from COVID-19. Hosted by the Bipartisan Congressional Caucus for Integrative Health and Wellness, together with the Integrative Health Policy Consortium, IHPC. I'm Dr. David Vogel, and as someone whose career has been focused on innovative models of care, I'm honored to be your moderator today. Our presenters are both innovative thinkers and pioneers. COVID-19 has shined a spotlight on key burning issues in our healthcare system, notably the opioid crisis and the urgent need for effective, non-opioid, non-drug pain management treatments. The pandemic has also pulled back the veil on our health system's disparities and racial inequities, worsening already difficult to access pain and addiction treatments. Today's presenters will not just lay out the problems, but also present real solutions. Both presenters are dedicated, forward-looking health professionals that are working within our federal system to create pioneering healthcare initiatives. Today's briefing is one in a series of briefings that IHPC has hosted together with the Congressional Integrative Health and Wellness Caucus, highlighting integrative health's impact on key metrics including cost, health outcomes, and patient satisfaction. IHPC is a nonprofit organization that represents more than 650,000 state licensed and nationally certified healthcare professionals. Its mission is to eliminate barriers to health for all. And among its important work is to champion the Congressional Integrative Health and Wellness Caucus. I want to make a special point here of inviting other members of Congress to join the Integrative Health and Wellness Caucus and play an active role in promoting a whole-person approach to health for all. And for the public listening, if what you hear today strikes you as important, please write or call your congressional representatives and ask them to join the caucus. Some quick housekeeping. You can submit written questions by clicking on the Q&A icon at the right-hand bottom of your screen's taskbar. We'll get to as many of your questions as possible. Also, today's presentation will have real-time subtitles. Our program today is being recorded and will be sent out to all participants within a week. It will also be available on the ihpc.org website. So let's get right to it. We start our program with welcoming remarks from our two co-chairs. And for those who aren't familiar with it, the Congressional Integrative Health and Wellness Caucus is a bipartisan forum for legislators to learn about and discuss new research and evidence-based practices from experts in the field of integrative health and wellness. The caucus also provides a platform to create legislative and regulatory opportunities that expand access to integrative health, like the pioneering pain management programs you're going to hear about today. To ensure our co-chairs could be here with us today on a day when there's a lot of activity on the Hill and votes in the House, our co-chairs have pre-recorded their remarks. First, we'll hear from the Honorable Congresswoman Judy Chu from California. Congresswoman Chu was elected to the U.S. House of Representatives in July 2009 and became the first Chinese-American woman elected to Congress in history. She represents California's 27th Congressional District. Congresswoman Chu currently serves on the powerful House Ways and Means Committee, which has jurisdiction over legislation pertaining to taxes, revenues, Social Security, and Medicare. She's a member of the Ways and Means Subcommittee on Health, giving her oversight over healthcare reform and crucial safety net programs, worker and family support, and oversight. She also serves on the House Small Business Committee, which has oversight of the Small Business Administration, and she is the co-chair, she's the chair of the Small Business Oversight Subcommittee. Please welcome Congresswoman Chu, and here are her remarks. Federally Qualified Health Center, also known as an FQHC. It's where Dr. Kohli has spearheaded a pioneering interprofessional pain management program that puts into practice many of the recommendations of the HHS Task Force. He's a founding member of the national nonprofit organization Integrated Medicine for the Underserved, and having worked in FQHCs for over 17 years, he has dedicated his career to advancing social justice, health equity, and working with underserved communities. Welcome, Dr. Kohli.
Thank you, Dr. Fogel, and thank you to the caucus, Congresswoman Chu and Walorski, and IHPC for inviting me to present. Today, I'm going to be talking about one federally qualified health center that has built a program to address pain that is aligned with the best practices that Dr. Singh just presented. I want to begin with a brief overview of federally qualified health centers. FQHCs are individual nonprofit entities that receive Section 330 grant funding from the Health Resources and Services Administration to provide primary care, behavioral health, dental, and other services in medically underserved regions throughout the country. FQHCs must accept patients with Medicaid and Medicare, private insurance, as well as those who are uninsured by a sliding fee scale. FQHCs came out of the civil rights era and LBJ's war on poverty, so they have a storied history of providing healthcare and other resources to historically marginalized and underserved populations. They're trusted members of their local communities, and there are over 1,300 health centers with over 12,000 sites nationwide, serving around 30 million people, thus making FQHCs the largest healthcare network in the country. FQHCs have added importance right now as millions of Americans are losing their employer-sponsored health insurance due to COVID-19, and as we'll discuss, FQHCs are the front lines with regards to chronic pain and opioid misuse. Next slide, please. Now, People's Community Clinic didn't start as an FQHC, but became one in 2012. The clinic was originally a free clinic started 50 years ago by volunteer doctors and nurses in a church basement to take care of students and others who didn't have access to health care. It's expanded to care for an increasing number of working Central Texas families. It's a patient-centered medical home as well as a community-centered health home, which means we recognize that most of health happens outside of the four walls of any medical facility. So we work in both the clinic and the community to improve health outcomes. Now you can see our new building on the right that we moved into in 2016. Last year we served over 18,000 unique patients, 85% of which identified as Latino, and 63% of our patients prefer another language, mainly Spanish. 41% of our patients are on Medicaid or CHIP, while almost half are uninsured. Next slide, please. Our impetus for this program lies in the structural issues that lead to health disparities, which can be an entire talk on its own. I'm going to try to summarize it through this map of Austin on the right, which shows life expectancy by zip code. Most of the west side of Austin has a higher life expectancy, indicated by dark greens, while on the east side, where many of our patients come from, where our clinic's located, it's much lower, which are the lighter greens and pinks. Now, this stems from a series of ordinances culminating in the 1928 Master Plan of Austin, along with subsequent federal regulations, which deliberately displaced communities of color. These decades of policies rooted in racism limited economic opportunities, education, access to healthcare, and often created a lot of trauma for individuals and communities. And this is what we mean when we talk about social determinants of health, that the conditions in which people live and work play a significant role in their overall health. The adage is that your zip code matters more than your genetic code. What we know about trauma, especially through data around adverse childhood experiences, is that it leads to higher rates of chronic diseases such as high blood pressure, diabetes, or cancer, as well as depression, anxiety, substance use disorder, and chronic pain. Studies show that emotional pain and physical pain activate the same parts of the brain, and there's a lot of overlap of the neural pathways. So people who have experienced trauma, which are a large number of our patients, may feel pain on their own, or it can exacerbate physical pain that they may have. Additionally, many have financial, housing, or food needs that can increase their stress, anxiety, and ultimately pain. One of the other major barriers here in Texas is that we did not expand Medicaid. The large majority of our patients with pain don't have access to imaging, specialists like an orthopedist or rheumatologist, or even physical therapy. They definitely don't have access to the growing number of evidence-based non-drug approaches. Without many options to help patients with their pain, opioids often end up being prescribed even without evidence of great efficacy. Now, we're lucky in that in our clinic, we don't have a lot of patients who've been prescribed opioids for pain, but we decided to build a program that effectively addressed trauma and pain as a way to improve patients' functioning and quality of life, but also to prevent people from ending up on opioids. In a lot of ways, this is a prevention program. And really, we had no alternative but to build it in-house, as is often the case in FQHCs. Next slide, please. Now, one specific intervention I wanted to mention, because it's pretty unique and plays a large role in improving our patients' lives, is our medical legal partnership. This program offers on-site legal services addressing health-harming legal needs, such as unlawful discrimination, tenants' rights, benefit denials, and more. In terms of our patients with pain, if someone is being threatened with eviction, that will increase their stress and typically their pain. Taking that stressor off their plate is usually really helpful. Furthermore, many of our patients aren't able to work and may be eligible for disability, so our lawyers can help with that process. Getting disability usually means getting a small monthly payment, which can help with financial stress, but more importantly, they're able to get access to Medicare and Medicaid, which then allows them to get the imaging specialists, physical therapists, et cetera, that may benefit their pain. We currently have 4 lawyers on staff, and they function as members of our healthcare team. This program was created and is directed by Keegan Warren Clem. Keegan was recently honored as a National Academy of Medicine 2020 Emerging Leader in Health and Medicine Scholar, only the second time a lawyer has ever received that award. You can learn more about the program through the links, and feel free to email her if you have any questions. I will say that now that I've experienced it, I can't imagine working without lawyers as part of our team. Next slide, please. Now, as Dr. Singh mentioned, it's important to work in an individual, multimodal, multidisciplinary fashion. Her team recognized 5 categories of treatment approaches, and at PCC we have something from each which patients can choose. What this does is allow the patient to work with the healthcare team to come up with an individualized program based on their preferences using this expanded toolbox. Next slide, please. And this is how the program looks in practice. A patient comes in to see their primary care provider. The PCP can prescribe medications or potentially do an interventional procedure like a joint injection if indicated. But they can also discuss the IPMP, and if a patient would like a referral, the PCP makes one, which then goes to our care coordinator at a setting. She will then contact the patient and let them know about all the different services within the program. The patient can then be referred to the different elements of the program based on their preferences. So that could be behavioral health, where most of our patients start, or our medical legal team, if there's a legal need that's impacting their pain. It could be our substance use counselor if needed, or nutrition, or an exercise, or a cooking class, or exercise, or it could be acupuncture, which includes full body acupuncture or ear acupuncture, following what is called the NADA protocol, which has been shown to be effective for trauma, stress, anxiety, and substance use disorder. Or even yoga therapy, which is more than just yoga. It's a one-on-one application of specific yogic tools, including exercises, breath work, meditation, and more, done in a trauma-responsive manner. Now, we were planning on adding massage therapy as it was budgeted in our grant, but COVID has put those plans on hold for now. The other place where patients can get referred to is our chronic pain groups, which is one of the cornerstones of our program. Next slide, please. So for those not familiar, group medical visits are an innovative value-based model where patients receive their medical care in a group. A provider has a face-to-face visit, so it's billable, but there's typically more time for education, information about self-management, peer-to-peer learning, and connection. Group visits are increasingly being used in underserved settings where so many patients are lonely and isolated. When patients are able to come together and realize that there are others who are going through something similar, they often feel less alone and more supported. Patients end up willing to try things that they might not otherwise, they make friends in the group, and they hold each other accountable. As one of my colleagues recently stated, often in our current model of care, we attempt to extract the individual in a way that fails to address the healing nature of community. For our groups, we adapted a curriculum developed by Paula Gardner, a physician in Massachusetts who had received a PCORI grant to create a program specifically in underserved settings. The groups are co-facilitated by our social worker, Kelly, our nutritionist, Diana, and myself. And each session generally includes a nutrition and cooking component, mind-body activity, usually some sort of movement, and most importantly, connection between group members. Now, one last point I'll make about groups is that it's a more casual interaction, which breaks down the hierarchy that often exists in medicine and builds trust. The health team learns more about the patient's concerns, as well as the inherent knowledge patients have around their own health. And this really fosters that patient-health team partnership that's central to shared decision-making. Next slide, please. One other key element of the program are weekly case conferences to discuss complex patients. Now, all the different folks I've mentioned in the IPMP come to these. Oftentimes, some of the first things we do are to stabilize crises and address social needs. So our lawyer and social workers are key to the discussion. One really important point about these case conferences is that, like the group visits that flatten hierarchies between patient and practitioners, these meetings do the same within our healthcare team. Everyone has their own expertise that they bring to the table, and we learn from each other. When more people are comfortable sharing their opinions, you're less likely to miss something, and overall this improves patient care. It also improves provider satisfaction and mitigates burnout. No one person has to do it all, since we all work together to figure out what exactly our patients need. A few of our team members say that these conferences are their highlight of the week. Next slide, please. This program is still very young, so we're in the process of collecting data. It's hard to evaluate pain because it's so complex. We're looking at pain and functioning, behavioral health and physical health measures, opioid usage, and ER utilization. But really, the ultimate goal is to improve quality of life. And we're piloting right now a tool called the Flourishing measures from the Human Flourishing program at Harvard. As many of my colleagues state, we're moving from what's the matter with you to what matters to you. Honestly, patients don't necessarily care about their scores on any of these metrics. They care whether they can get back to doing the things that they love. So that's what we're trying to accomplish. Next slide. So COVID-19 has been pretty brutal here in Texas, especially recently, and it's disproportionately affecting our patients. Many are deemed essential workers who are more exposed to the virus. Many have underlying health conditions that put them at higher risk for complications from the disease, and many were already struggling financially before this all hit. Given these factors and the fact that patients may be less mobile and more isolated during this pandemic, we anticipate that patients living with chronic pain will experience more trauma, stress, depression, anxiety, substance use, and ultimately more pain. Unfortunately, the virus has changed so much about how our clinic can operate. Normally on Wednesday afternoons, I'd be in our chronic pain groups. Instead, as you can see in the photo, I'm here standing outside in full PPE in 100-degree heat, swabbing folks in our drive-thru line. We've had to cancel so many of our in-person offerings when patients may need them the most. But despite this, there's a lot we can do, and we're starting to shift how we provide care. We've begun offering virtual behavioral health, legal care, one-on-one yoga therapy, and substance use counseling. And we plan on bringing back virtual groups, nutrition, and more. We're looking at whether we can offer videos on demand for mindfulness, acupressure, or qigong. We're also working on protocols to safely restart acupuncture. Next slide, please. Now, in terms of challenges, we do have long waits for many of our services, including acupuncture. This is mainly because these services may be limited to a day a week, since they're grant-funded and generally not reimbursable in FQHCs, which is one of the biggest barriers to creating a sustainable program. And with COVID, as we start moving to virtual visits, we're recognizing that some of our patients have limited internet access or don't have a lot of experience with technology. We're also losing the in-person connection, especially from groups, which contribute so much to healing. We'll see with time what works and what doesn't, and have to adjust as FQHCs always have. Next slide, please. So I want to close with a couple testimonials from patients. The first is a 6-minute video that you can watch on your own. You'll get the slides, and the link will be on there. Next slide, please. But the second is from a patient that we're calling Gloria, and is translated from Spanish. I don't have time to read the whole testimonial, but some things to note. Now, Gloria had an aversion to meds initially, so was looking for alternatives. She thought physical therapy was helpful. She joined our groups and enjoyed being with other people. Therapy was really important to her to help with her self-esteem. She changed her diet, which she thought really helped, and began drinking certain herbal teas, which culturally was something she was comfortable doing and which was reinforced in the group. She also got more family support. And according to her, there really wasn't one thing that worked. It was a process and required patience. And one line that stuck with me, and this is what she said is, but in the most difficult moments, none of these things took away my pain. What they did was help me support my body so that I could stay strong, so that I could continue to face or bear my pain. We have to remember that people with chronic pain will likely still hurt. The goal has never been to completely eliminate pain. The question is whether they can overcome it and learn the tools to be more resilient, to still be able to live the life that they want, to do the things that they enjoy. That's the ultimate goal of this program, and I believe the recommendations from Dr. Singh's team as well. Next slide. Good job.
You're really an inspiration to me and many others. Initiating something like this in an QHC is really an accomplishment. Okay, let's try to we're running a little bit over, but let's try to get to a question or two. I'll try and condense them. For Dr. Singh, you've touched on this a bit already in your presentation, but a lot of the questions from the audience are about steps to take to remove the barriers that you spoke about in your presentation. Can you comment on this and what the most effective path forward is?
Well, so thank you so much, Dr. Fogel, for all that, and it was great to hear Dr. Kohli as well. I will say that it's important, one, to continue to do such webinars and to get all the different folks out there, the different organizations, to really share some of the common themes that we've heard about today to Congress so that they can be appropriations for this. It's really an investment in our nation to get folks out to better clinical outcomes in terms of functionality, quality of life, and even the idea that as we do better innovations and research and development, I think it is fair to say that we can hopefully get into preventive mode and to really help those who are suffering immensely with the various different treatment modalities. We have oftentimes the solutions. We just need access to them. And so I think better understanding the empathy and compassion that's always necessary in medicine, along with the science, will give the confidence to our lawmakers to consider these options so that folks out there can really get back to work, a productive life, and it affects so many people that I think that their constituents would definitely appreciate it.
Great, thank you. Let's see, Dr. Kohli. How many other FQHCs in the country have pain programs like yours, and what's needed to increase that number?
Thank you, Dr. Fogel. Yeah, you know, the bottom line is I actually don't know, and I think I know that there are many right now because we know through like my work with IM for Us, you know, we created that conference to really share best practices of what's happening in underserved communities and around integrative care. But throughout the 10 years that we've been having conferences, we've had multiple FQHCs promoting these pain programs that they're doing. So we know that there are some in rural and urban areas in like California, in Massachusetts, Illinois, Ohio, Arizona, et cetera. But as far as I know, I haven't seen a large survey to see what FQHCs are doing for pain, what the challenges are, what they need. The National Association of Community Health Centers, I know, has also had a collaborative with certain FQHCs that are working on some of these issues. And so it might be great to work with them and Bureau of Primary Healthcare, who oversees the FQHC program, to really, you know, conduct a survey to really see what the needs are and what people are already doing. I think one of the other challenges right now is that you know, many of these non-drug approaches aren't reimbursed in FQHCs, and that's, you know, very variable based on the state that you're in. In Texas, you know, we don't have coverage for acupuncture or some of these other services, and so we've had to be really innovative about how we've done this. So I think, you know, it's going to, you know, these grants are great, but they're very limited in what we can do with them. And I think if we can figure out ways to make these services reimbursable in FQHCs, I think it can make this more sustainable.
Great, thank you. Unfortunately, I see we're coming up on the hour and we don't have time for more questions. So we've seen today how COVID-19 has stressed our health system in ways none of us could have imagined. It's really underscored long-standing disparities and inequities in healthcare. This pandemic has distracted us from the national pain management crisis that was already raging. As everyone has learned today, there is a path forward and there is still urgent work to do. Many of the non-pharmacologic pain management practices highlighted today are not covered by insurance, making them inaccessible, while pharmacologic approaches, including opioids, are. What appears critical is for HHS to develop the implementation plan for the task force recommendations, and judging from our turnout of our listening audience today, the integrative health community needs to be a part of this planning process. We also mustn't lose sight that FQHCs are the bedrock of care for over 30 million people in the country and are our main healthcare safety net. We need to make it possible for all FQHCs across the country to implement non-pharmacologic pain treatment programs as modeled by People's Community Clinic. With this in mind, I want again to invite all members of Congress to join the Caucus for Integrative Health and Wellness and to learn more about initiatives like the ones presented today. I want to thank our caucus co-chairs, Congresswomen Jackie Walorski and Judy Chu, and Congressman Tim Ryan for the leadership and for championing the inclusion of provisions into both the Labor HHS Appropriations Bill and the Veterans Affairs Appropriation Bill. Finally, I want to thank all of you who have attended today, which includes